The topic for discussion is furcation involvement. So here let's get into the introduction and understand what furcation is. So here in the picture you can notice there is a yellow color point which is named as entrance. So this is the furcation entrance. This furcation is the area in between the two roots, in between the two divided portion of the roots. This area is called as the furcation. So it's an area of complex anatomic morphology and it is difficult or even impossible to debride by routine periodontal instrumentation. So this furcation involvement occurs when there is so much attachment loss that extends into this furcation area. So if the progression of the periodontal disease is not stopped, if its progression is not stopped, then the attachment loss will extend in order to expose the bifurcation or trifurcation of the multi-rooted teeth. Let's see what bifurcation and trifurcation is later. So this furcation is a diagnostic and a therapeutic dilemma. Now next in the picture you are noticing a component called as root complex. So this root complex includes the root cone and the root trunk. So this root trunk is the undivided portion of the root. In the picture you can notice that this root trunk is occupying the portion in between the cemento-enamel junction to the point where the root is starting to divide. So this is the undivided portion of the root, whereas root cones are the divided portions of the root, right? So this root cone and root trunk comprise the root complex. Next, we will learn another important terminology called as furcation entrance. You have seen in the picture the yellow point which is representing the furcation entrance. Depending upon the number of roots, there will be the furcation entrances. So this picture is the maxillary molar in which there are three furcation entrances. One is the mesial furcation entrance, other one is the distal, and the third one is the buccal furcation entrance. So in the middle you have the furcated region. So if the attachment loss is extending till this area, if there is bone loss, then it is called as furcation involvement. Always remember, whenever there is furcation involvement, it gives us a diagnosis of advanced periodontitis. Next, in this picture you can notice the furcation fornix, a red color lining. So this furcation fornix is the roof of the furcation. Next, you will learn another important terminology called as degree of separation. So degree of separation is the angle of separation in between the two roots, or to be more precise, what are these? These are the root cones. So the angle in between the two root cones is called as the degree of separation, whereas the divergence is the distance in between the two roots or the root cones. So you can notice in the picture that the divergence is increasing in the apical direction. So as we progress apically, the divergence or the distance in between the roots is increasing. Next, here you can appreciate the maxillary molar in which there are three different entrances, right? The first one is the mesial entrance, the second one is the buccal entrance, and the third one is the distal entrance of the furcation. Suppose if it is a premolar, if in case the premolar has two roots, the maxillary premolar which has two roots is having two furcation entrances. Whereas the mandibular molars also have two roots, they will also have two furcation entrances, that is lingual entrance and the buccal entrance. So depending upon the number of roots, there are the furcation entrances that are present. Next, we will learn about the etiologic factors. The primary etiologic factor that causes the furcation involvement is the bacterial plaque. So because of this plaque, there will be inflammation, and because of the long-term presence of the plaque, there will be inflammatory consequences, and because of which we will see the attachment loss. And if this attachment loss extends to the furcation area, it is called as furcation involvement, and we give a diagnosis of advanced periodontitis. However, the extension of the attachment loss into the furcation area depends on some factors. Those are the local anatomic factors and the local developmental anomalies. Under local anatomic factors, we have two important components. Those are the root trunk length and the root morphology. Under local developmental anomalies, we have the cervical enamel projections. Now we will see about the root trunk length. So we already know that the root trunk is the undivided portion of the root. You can see the difference from A picture to D picture. The length of the root trunk is varying. And also I want you all to notice that A picture has widely separated root cones, whereas the B picture, the root cones, the degree of separation is very less. Okay, the angle of separation is also less, and the distance or the divergence is also less. Whereas C picture, there are fused roots. Okay, in the D picture, in the picture you can appreciate that the root trunk is very small, and also there is a projection of the enamel into the furcation area, which is called as the cervical enamel projection. Now you can see a short root trunk and a long root trunk in the next picture. So here the short root trunk will have early involvement of the disease. Why? Because the attachment loss, if it extends to this furcation area, it will result in furcation involvement, and this furcation area is nearer. So the attachment loss will occur early as the furcation entrance is nearer because of the short root trunk. Whereas in the second picture you can see the long root trunk. So in order to the furcation to get involved, there should be so much attachment loss, and it will take a lot of time. But remember, if in case of long root trunk, if the furcation is involved, the prognosis is very poor because it will be difficult to instrument this area. Whereas a short root trunk, it will have early involvement of disease, but there will be some amount of treatment options depending on the grade of the furcation. Whereas the long root trunk, it will be difficult to instrument, and the attachment loss should be so severe such that the furcation is involved. Next, we will learn about another factor called as root form. So the mesial root of most mandibular first and second molars and the mesiofacial root of the maxillary first molar are curved to the distal side in the apical third. You can notice in the picture the distal bend of the root, right? So these curvatures will result in the endodontic problems. So that is, there might be perforations during the endodontic therapies, which will complicate the instrumentation also. And second picture, you can notice fluting. So there are flutings on the distal aspect of some roots. So because of these flutings and curvatures, there will be complications in the treatment plan. Another important point is the interradicular dimension, which is the distance in between the two roots again. So because of this interradicular dimension, there will be complication during the instrumentation. So if it is widely separated roots, there are many treatment options. The roots can be thoroughly debrided or instrumented. Suppose if the roots are fused, or if the degree of separation is less, then instrumentation gets difficult. Next, we will learn about the anatomy of the furcation. We have already seen that the anatomy of furcation is complex. So there might be bifurcational ridges, concavities in the dome, there might be accessory canals, which will all complicate the instrumentation. And there might be some additional procedures that have to be performed in case of this complex anatomic morphologies. Suppose if there is a concavity, you need to reduce or either eliminate by performing the odontoplasty, and then you will be performing the other surgical procedures. Next is the cervical enamel projections. We have already seen it. So this projection of the enamel into the furcation area is called as the cervical enamel projections, and this cervical enamel projection will form a local factor for the development of the gingivitis and periodontitis. So it will complicate the scaling and root planing. It will affect the plaque removal in the area. Next, we will learn about the diagnosis of furcation involvement. It is performed through clinical probing with the help of the neighbors probe. Okay, the probe that is designed to measure the furcation area is called as a neighbors probe, as you can see in the picture. So it is in the picture you can see that the neighbors probe, we are using it to measure the presence and the extent of the furcation involvement. Radiographs can also be used in order to diagnose the furcation, but sometimes the clinical findings and the radiographs are inconsistent because of the superimposition. Especially in case of maxillary molars where there are 3 roots, there might be superimposition and there might not be proper diagnosis of the furcation involvement. So for diagnosis of furcation, we will use the clinical probing technique and the analysis of the radiographs. And after giving the local anesthesia, we will perform the transgingival probing, which is also used to define the anatomy of the furcation defect. Next, we will see about the indices of the furcation involvement. The first one was given by Glickman in 1953. Glickman divided the furcation grades into 4. So that is grade 1, grade 2, grade 3 and grade 4. Grade 1 is an early stage of furcation involvement. Remember, grade 1 is incipient or early stage of furcation involvement. In the early stage, there won't be any radiographic changes. However, there will be probing depth because the early bone loss is manifesting as increase in the probing depth. Okay, but there will be no radiographic changes in grade 1, whereas grade 2 is cul-de-sac. That means one or more of the furcations of the same tooth are involved. Okay, and if multiple defects are involved, they do not communicate with each other, because of which it is cul-de-sac. Whereas in grade 3 there is no bone that is attached to the dome of the furcation, and the furcation entrances are communicating with each other. So whenever we pass a periodontal probe, the probe will pass through and through to the furcation area. Whereas in the D picture you can appreciate the grade 4 type of furcation, in which there will be recession, and clinically you will be appreciating the furcation involvement. So there will be a tunnel in between the roots of such affected teeth, and the interdental bone is destroyed and the soft tissues have resided apically. Whereas in the grade 1, 2 and 3 there will be no recession of the soft tissues, whereas in D there will be recession of the soft tissues and there will be furcation involvement. Another classification was given by Tarnow and Fletcher. This is a sub-classification and it measures the vertical depth from the roof of the furcation. So there are 3 subclasses. First one is subclass A, subclass B and subclass C. In this subclass A, the distance from the roof of the furcation is 3 mm or less. That is, the vertical bone loss from the roof of the furcation is less than 3 mm or equal to 3 mm, whereas in B the vertical bone loss is 4 to 6 mm, whereas in the C the vertical bone loss of 7 mm or greater is seen from the roof of the furcation or the furcation fornix. Next, we will be seeing how to treat the furcation involved teeth. So this is the therapeutic classification which you are seeing. So previous one was the indices for the furcation involvement, whereas this is the therapeutic index. For the purpose of treatment, the classification was given. In the class 1, there will be oral hygiene procedures and scaling and root planing are performed, whereas in the class 2, localized flap procedures along with odontoplasty, osteoplasty and ostectomy are performed, whereas in class 2 to class 4 you can perform the periodontal surgery, endodontic therapy and restoration of the tooth may be performed. Now we will see the non-surgical management of the furcation involvement. The non-surgical way is the effective way of producing a stable result. In this, you will be giving the patient the oral hygiene instructions and you will perform the scaling and root planing. However, the scaling and root planing is difficult because not all the furcation areas can be entered by using curettes. So special curettes have to be used like Demarco curettes, Q10 furcation curettes and Mini 5 curettes. However, it is very frustrating to instrument a furcation area, right? And the patient should be made aware of the furcation, and specific oral hygiene tools have to be advised. In the first picture you can see the perio aid, that's a toothpick holder, and in second picture you are seeing the interproximal brush. So in this way you can non-surgically manage a furcation area. Next comes the surgical therapy. In this, the first one is the osseous resection. In advanced cases of class 2 or class 3, you will open the furcation into class 4. So it will create access for the patient to maintain a good hygiene. But however, it is of limited usefulness. But in the compromised cases wherein we can't extract the teeth or wherein the conservative therapy cannot be performed, in such cases this osseous resection can be performed. Osseous resection is like performing osteoplasty. You will shape the bone, you will remove the bone in order to make the area cleansable, in order to for the patient to maintain the area. So the main goal is to create access for the good hygiene. Next one is regeneration of the furcation area. Some studies state that there is no success, whereas some studies state that there's greater vertical bone fill with the use of bone grafts and the barrier membrane technology. However, there are controversies with this, but different grafting materials have been used in order to regenerate the furcation area. The other therapy is the root resection. So this root resection is indicated in the multi-rooted teeth with the grades 2 to 4 furcation involvement. So it can be performed either on the vital teeth or on the endodontically treated teeth. But usually it should be performed on the endodontically treated teeth because it will be convenient both for the patient as well as the clinician. So if it is a vital root, it will be distressing for both the patient and clinician, and if subsequently an unfavorable event occurs like perforation, fracture of the root or inability to instrument the canal, so that's why you need to perform the endodontic therapy prior to the root resection. So here in the picture you can see that a root is resected, that is the mesial root of the second molar, mandibular second molar is resected, it is removed. So how do you plan for root resection? So you will plan the root resection in such cases wherein the teeth is very critical for the overall treatment plan. You need the teeth to be present in the oral cavity. So in such cases, you will be performing the root resection in order to maintain the teeth in the oral cavity. And you will perform the root resection of that root which is having the greater attachment loss. Okay, if you perform, suppose in this case, you are removing the mesial root. Okay, the mesial root, there is lot of attachment loss, but the distal root, the attachment loss is not so severe so that it can be maintained in the oral cavity only with this root. Okay, and also in patients with good oral hygiene and low activity of caries are also suitable for root resection. So which root to remove will be decided on the root that will eliminate the furcation. If you eliminate the root, then the furcation will also be eliminated. So you should always remove the root with the greatest amount of bone and the attachment loss. Okay, so if the root is removed, the furcation has to be eliminated. So based on that, you will be deciding the root to be removed. Next, we will be seeing about the hemisection. This hemisection is splitting the two rooted teeth into two separate portions. Okay, a single tooth is divided into two separate portions, and it is made like a two teeth. So this is performed in cases where there is greater interproximal bone loss. So in order to eliminate the furcation in this interproximal area, you will divide the tooth into two halves. So here in the picture you can see that there is a greater interproximal region in this molar tooth. So you are dividing the tooth into two halves, and these divided portions will function as two separate teeth. The other options also for treating the furcation area, in case of severe cases, you will be performing the extraction of the teeth and placement of dental implants. Here we conclude the topic by saying that the furcation involvement is one clinical finding that gives the diagnosis of advanced periodontitis, and it has a potentially less favorable prognosis for the affected teeth. And the furcation involvement therefore presents both diagnostic and therapeutic dilemma and is an area of complex anatomic morphology. The important questions from this topic are the indices for the furcation involvement, which are asked even for your MCQ point of view, and you need to know about the terminology of the furcation, and the diagnosis and the treatment of the furcation are other important questions from this topic. Thank you everyone for your patient listening, and